مساء الخير. Thank you very much, Hels, for your informative presentation. I will present the other approach, which is in the bag IOL implantation, followed by pars plicata, posterior capsulotomy, and anterior vitrectomy. The most common cause for pediatric cataract is genetic. It's usually bilateral, followed by other causes such as trauma, prematurity, inflammatory, infection, or metabolic diseases. So if we decided to implant the IOL primarily, should you do the posterior capsulotomy before IOL implantation or after IOL implantation? Let's agree that there is no universal agreement on whether the IOL should be implanted before or after the posterior capsulotomy and anterior vitrectomy. However, the American Academy of Ophthalmology strategy is to do posterior capsulotomy after in the bag IOL implantation. The anterior approach, like my dear colleague Hels mentioned, it's preferred by the anterior segment surgeons. However, it has a lot of disadvantages, such as the difficulty and the experience needed for the posterior capsular rhexis, difficult IOL implantation in a non-intact capsule bag, anterior vitreous phase disruption, and the residual vitreous in the anterior chamber. If we inject the triamcinolone, there will always be residual vitreous in the anterior chamber that we did not visualize without using the triamcinolone, and hence it has a higher risk of retinal detachment, although there is a wrong concept that the pars plicata approach might have. It's not evidence-based even that it has a higher incidence of retinal detachment, but on the other hand, if we leave vitreous in the anterior chamber, it has a higher incidence of retinal detachment. And there is a high risk of IOL dislocation and decentration, like my dear colleague Held mentioned. In the posterior or pars plicata approach, the IOL implantation is implanted in an intact capsular bag. There is no disruption of anterior vitreous face, and there is elimination of vitreous wick through the corneal tunnel, and the OVD can be removed without fear of engaging vitreous. So we conducted a study in Abu Rish Pediatric Hospital by our team. The aim of the study was to determine the incidence or risk factor of RD following pediatric cataract surgery, and to compare the incidence of RD in Limbers versus pars plicata approach. And the conclusion of our study that there was no significant difference in the incidence of RD in using the anterior or the posterior approach. However, the incidence of RD was higher in cases who had secondary glaucoma. So what is the site of incision? In children less than 1 year, it's 2 millimeters from the limbus. In 1 to 4 years, it's 2.5 millimeters from the limbus, and over 4 years, it's 3 millimeters from the limbus. So I would like to thank my dear professor, Dr. Hala Hilali, for sharing this demonstrative video with me. We start by doing the MVR wounds, and then we do the keratome wounds, followed by the anterior capsular rhexis. We should be careful with the anterior capsular rhexis in the pediatric age group, as they have an elastic anterior capsule. So we use the ripping movement. We pull towards the center to avoid the extension of the rhexis, and which might lead to this decentration of the IOL later on. And then we're done with the rhexis. We do the hydrodissection, followed by phacoaspiration of the lens material. IA is done, and now we have a beautiful intact capsular bag. We fill the bag with the viscoelastic material, and then we implant the IOL in the bag. It's perfectly centered. And then we suture the keratome wound to preserve the intact globe and preserve the IOP. Now, after we close the keratome wound, the main wound, we use the MVR to make the pars plicata incision. And then the posterior capsulotomy is done using the vitrector. The size of the posterior capsulotomy, like my dear colleague Hels mentioned, at least 4 millimeters. It's usually 1 to 2 millimeters smaller than the optic size. And then we do adequate anterior vitrectomy. There is no end point for the anterior vitrectomy. We cannot say when to stop doing the anterior vitrectomy, but it should be sufficient to prevent the posterior capsular opacification later on. So, to conclude, posterior capsulotomy and anterior vitrectomy are essential surgical steps in the management of pediatric cataract surgery below 5 years. Surgical approach is best left to the individual surgeon's preference and experience. A comparative study conducted in a British pediatric hospital, which was mentioned in details by Dr. Hills, concluded that the limbal approach had longer time of surgery and higher intraoperative and postoperative complications. American Academy of Ophthalmology recommends pars plicata approach as the safest and most effective technique for posterior capsulectomy and anterior vitrectomy while ensuring a well-centered IOL and a clear visual access. Thank you.